Hello everyone, and for today's lecture we're going to be discussing schizophrenia and other psychotic disorders. Schizophrenia is one of those mental disorders that has been studied for quite some time now, and so that's why it gets its own chapter here, but also because of the severity of schizophrenic symptoms. So we're going to be going over in detail biological factors and psychosocial factors, treatments. But before we do that, we have to discuss the overall mental disorder itself and some characteristics about that. The hallmark of schizophrenia is the psychosis, a significant loss of contact with reality. And I wanted to read this to you. The disorder is characterized by an array of diverse symptoms, including extreme oddities in perception, thinking, action, sense of self, and manner of relating to others. So there's a lot of components to this. The risk here, lifetime prevalence 1%, still very low. Age of father over 50. That's a risk factor. Parent in a dry cleaning business, that's one of those, kind of a factoid, kind of an oddity. And remember, there's still really no clear-cut cause for schizophrenia. We don't know the exact etiology of the disorder itself. So, but we're just noticing a higher prevalence rate there. Some countries have higher prevalence rates than others. The onset is age 18 to 30, and gender, we see it more in males and females. Onset of schizophrenia here by age. This is interesting. Again, see the males is a little bit higher than the females, but okay. But if we look at this by age group, you'll notice, remember, 18 to 30 was the key there. After the age of 30, it drops down to very, very low. In fact, the male population drops almost down to 0 after 40 years of age, whereas we see in females between 45 and 49, there's another little spike there. Okay, some hallmark symptoms besides just that overarching break from reality and psychosis. There are delusions, there are hallucinations, there is disorganized speech and behavior. And if we dive into the delusions and become a little bit more specific with these, we'll notice that there's erroneous beliefs. There's fixed and firmly held beliefs, that these erroneous beliefs are fixed and firmly held despite clear contradictory evidence. There's disturbance in the content of thought. And some examples that they give you here is external agents control thoughts. They believe that somebody is out to get them, somebody is always watching them, kind of a thing. Neutral environmental event has personal relevance. So it could be that somebody's on TV and they're speaking about the weather or something, and they believe that that individual might be actually speaking to them and not anybody else. The hallucinations, we see sensory experience here, seems real but occurs in the absence of any external stimulus and can occur in any sensory modality. Most often is auditory, so but they can be visual, they can be various odors and stuff as well. Okay, the disorganized speech was the last characteristic here. Failure to make sense. A lot of times they will refer to this as word salad, meaning that all the words are there to form the sentence, but they're stated in a different order so that they don't make sense. Despite conforming to semantic and syntactic rules of speech, disturbance in the form or the content of thought. Okay. And a little bit more on the disorganized behavior. You have impairment of goal-directed activity necessary for daily functioning. So there's poor hygiene. Their activities of daily living are oftentimes missed or not paid attention to. And then at the very bottom there you have the catatonia, and what that means is that they have inability to move. That sometimes you'll hear it as a catatonic state. Okay. In schizophrenia, they have broken up the symptomology into positive and negative symptoms. The negative symptoms of schizophrenia relate to an absence or deficit of normally present behaviors. So if you think of negative, you think of an absence or deficit of behaviors. For example, reduced expressive behavior, right? Flat affect, or reduced motivation. Okay, so in this regard, again, their affect does not match the situation that they're in. If something really bad happened to one of their loved ones, they might not be able to express that emotion as sadness. Okay, or they just don't express it in a way that it would be natural to be very, very depressed or very sad about that news. So it's a reduced expressive behavior or flat affect. Now the positive symptoms, so when you think negative symptoms, you think the absence, right? Positive symptoms, you think of something that you can see and something that's being manifested, right? Like an excess or distortion in normal repertoire of behavior. So here's where you have the examples of hallucinations, delusions, and disorganized thinking. Okay? You can outwardly see the individual where they're talking to somebody or they're hearing somebody and they're talking to themselves and that kind of thing. So that's a positive symptom of schizophrenia. There are also several subtypes. We have paranoid schizophrenia, absurd, illogical organized beliefs. That would be a paranoid schizophrenic. Disorganized schizophrenia is disorganized speech and behavior. And here's that flat or inappropriate affect again. And then the catatonic that I alluded to just a little bit, where they have pronounced motor signs that reflect great excitement or stupor. Okay, and that stupor is the one where they might not have, they might be in like a frozen state, catatonic. Okay, here's your e-lecture topic item. Please complete this and submit it with your discussion thread. Okay, we are also going to talk about some other psychotic disorders. So we have the schizoaffective disorder, features of schizophrenia and severe mood disorders. We have schizophreniform disorder. It is a schizophrenia-like psychosis, but lasting only about 6 months, less than 6 months. There's the delusional disorder, delusional beliefs with otherwise normal behavior. Okay, so we don't see the other characteristics of schizophrenia, just the delusion part. And then the brief psychotic disorder. Okay, this is a sudden onset of psychotic symptoms or disorganized speech or the catatonic behavior, any of those, but for a very brief amount of time. And remember, with all of our mental disorders, again, we're speaking about them on a continuum. And the DSM-5 is very specific on the time frame in which these disorders take place. So if it doesn't last over 6 months, then there's not going to be a labeling of schizophrenia for the most part. Okay, and then on here, what you're looking at is the risk of developing schizophrenia. And looking at the family components. So if you look at like right in the middle, your parents, if one or more of your parents had schizophrenia, you have about a 6% chance. Okay, fraternal twins, we see that goes up to maybe 17% there, whereas in identical twins, we're all the way up to about 48%. So if one of the twins shows signs of schizophrenia, it's very likely that the other one will as well. So what this is telling us is that there is a strong genetic component, but at the same time, it's not a 100% causal component. Remember, identical twins are identical in every way. Their genetic makeup is identical. So if it was just because of the genetic component, the concordance rate would be 100%. If one twin showed signs of schizophrenia, the other one would as well. So we know that there is a genetic component, but there's also some kind of an environmental component also, and we'll talk about that in a minute. Okay, I kind of alluded to this, as the influence of genetics. The reason why we study the twin studies is because of what I was just saying there. They're also looking at adoption studies. So let's say that you take two identical twins and they're raised apart in two totally different families. We still see that concordance rate of 48%. But it's not 100%, and so it might be because of the different environments in which they're being raised. Or there's some kind of an environmental trigger that the possibility, the symptomology is there. The individual is predisposed to that, but it doesn't manifest until this environmental factor or this trigger occurs. So biological factors, and there's a lot of biological factors, a lot of psychological factors, but we really still are on the kind of the beginnings of knowing why these symptoms occur. Okay, it could be due to a virus, okay? And the reason why we say that is because more individuals who suffer from schizophrenia were actually born in the late fall or winter months, okay, during flu season. The rhesus incompatibility, that's that Rh factor that some mothers deal with their newborn children. There's early nutritional deficiencies and maternal stress. There's also pregnancy and birth complications. Okay. You see how a lot of these are very general. Birth complications. Well, that could be just about anything, and that really tells you where how broad this really is, because we don't know the specifics. Okay, so if we look at this, you have the multiple genetic factors, like we were talking about, and then you have environmental factors on the other side. And the current thinking emphasizes the interplay between the genetic component and the environment, or you can think of it as like triggers. And something has to happen that brings these things together for the most part. Okay, some other biological factors. Brain lesions that lie dormant until normal developmental change occurs. That's a possibility. Okay, so again, maybe a genetic component. It's kind of like somebody who has the genetic predisposition for an aneurysm, a very thin wall in one of their arteries, and never manifests until they're in adulthood, and then it ruptures. Changes expose problems resulting from this brain abnormality, and then developmental precursors may include a variety of abnormalities. Okay. Also, again, like I mentioned to you, there's going to be a lot of these biological factors. You have the neurocognitive deficits found in people with schizophrenia. We see things like attentional and working memory deficits. We see eye tracking dysfunctions. Okay. So again, this kind of leads back to there is a genetic predisposition because of the eye tracking, because of the working memory deficits, but that doesn't necessarily mean that they will show signs of schizophrenia later in adulthood. At least it's not nothing that we've seen to where we can say it's a cause and effect. And some more biological factors like impaired social cognition, difficulty recognizing emotion in facial expression or speech, loss of brain volume, enlarged brain ventricles in some patients, and gray matter loss. That's one thing that we see in those who are suffering from schizophrenia, is that we see these large ventricles, lateral ventricles. And the reason for the larger lateral ventricles is because of the loss of brain matter. So less brain density, larger ventricles or open space in the brain. And then white matter, also with a reduced volume we have seen. Okay, what about disrupted brain functioning? They're less efficient at challenging tasks, and we see temporal and frontal lobe impairments. Difficulty handling normal stress levels, links to head injury, and we also see dopamine and glutamate. And dopamine and glutamate, we see very high levels of these drugs, and when we talk about pharmacological treatments, we'll be focusing on that decreasing of dopamine in the brain. Okay, so the diathesis stress, we've seen this before, but we're looking at, there's genetic components, there's prenatal, perinatal events. Those lead to brain vulnerability, but they don't lead to schizophrenia. They lead to a brain vulnerability, and then there is maybe stress that comes into play, maybe developmental maturation processes that come into play, and then the combination between those two is what result in the psychosis. So that would be your diathesis stress model. Okay, and then we'll talk about some treatment here. Pharmacological approaches to treatment. We have the first generation antipsychotics, and that would be your Haldol or Thorazine. These are going to be very, very strong medications that go in and decrease that dopamine in the system. Okay. Second generation antipsychotics, Risperidol, Seroquel, Abilify, some of these. Now, these are not focusing as much on dopamine. Some of these actually focus on serotonin and bringing down those levels also, because we know that with hallucinogenic drugs, they cause an increase in serotonin. So here's where we're trying to decrease the serotonin and try to help with those positive symptoms of hallucinations and delusions. Okay. Estrogen, an idea there, and then the side effects. The side effects primarily being that if you decrease the dopamine in the system, then you're going to interrupt motor functioning. Okay, because the motor functioning is dependent on that dopamine in the system. And that's why the first generation antipsychotics would cause movement disorders. You might hear the term tardive dyskinesia. That's a severe movement disorder that they would cause. The second generation are a little bit better at this because they're not just targeting that dopamine. Okay. And I think there was anything else, but I think that does it for the side effects. Okay. And then you have the psychosocial approaches to treatment. Here you're looking at family therapy, case management. Case management here, kind of like the bottom one with the individual, individual treatment kind of hand in hand, but the case management here is trying to, all you can do is try to decrease the symptoms. There's no cure for schizophrenia, so you're trying to bring them into a state where it's the best that they can be at that level, so that they can still complete their activities of daily living and live in a safe environment and that kind of a thing. Social skills training, cognitive remediation, cognitive behavioral therapy, all of those things should go hand in hand with this. Ideally, it'd be nice if all of these were done together, as well as some of the pharmacological treatment as well, right? And so ideally, this is the best approach that we have for treating these individuals at this time. And that's it for this chapter. Thank you.